Good afternoon, everyone, and welcome to our latest webinar in the IHPS Impact and Health Policy Skills series. This is our final webinar for the 24-25 academic year, and it's our privilege to have two of our leading experts at UCSF on the health workforce speak to us today. And so we're really delighted. I'll introduce them in just a moment, and they'll present, what I think will be a very exciting high-level webinar on health workforce policy and development in the United States. Before we do that, just want to let folks know that on May 8th in the afternoon, we are having a half-day workshop on having effective meetings with policymakers, particularly legislators. And so please sign up for that. For those of you that are affiliated with the Institute for Health Policy Studies, the information's in our newsletter, and I know we've sent it out across the campus to folks. So please sign up for that workshop. It's filling up fast. For today's webinar, our two speakers are Dr. Beth Mertz and Dr. Uli Munk. Dr. Beth Mertz is Associate Director of Research at HealthForce Center at University of California, San Francisco here, and HealthForce is our go-to place for all things health workforce. And in this role, she's responsible for developing new research opportunities and cultivating faculty connections. Dr. Mertz is also professor in the UCSF School of Dentistry's Department of Preventative and Restorative Dental Sciences, with a joint appointment in the UCF School of Nursing's Department of Social and Behavioral Health Sciences. And she's also affiliated with the Center to Address Disparities in Children's Oral Health and the Philip R. Lee Institute for Health Policy Studies at UCSF. And her work covers a broad range of health workforce issues, primarily focused on dental care. Dr. Uli Munk is faculty at HealthForce at UCSF. Her primary appointment is as associate professor in the UCSF School of Nursing's Social and Behavioral Sciences Department. She's also affiliated faculty at the Philip R. Lee Institute for Health Policy Studies. Dr. Munk is a nurse practitioner and health services researcher. Her research interests include the healthcare workforce, opioid prescribing patterns, and quantitative methods. And she has particular expertise in analyzing large administrative claims data and data from large surveys. And so we're really delighted to have both of them with us today. Just as a reminder, as always, we have a Q&A forum for these webinars, not the chat function. So if you have questions, please put them in the Q&A forum, and please, put them in the forum, as they enter your mind. We are going to hold off discussing Q&A until the end, but yeah, please, as questions come up, don't be shy about putting them in the forum. And with that, I'm going to go off camera and invite Dr. Munk and Dr. Mertz to share their slide deck and start their presentation.
Thank you so much, Janet. All right. I will kick things off. Uli and I are going to share this presentation, go back and forth, and I'll just start with doing a quick overview. Next slide. As Janet mentioned, I'm Associate Director for Research at HealthForce Center. Janet, Beth Griffiths, and Uli are all also affiliate faculty at HealthForce Center, so I'm going to just give a little orientation to the broader work that we do. I will then turn it over to Uli. She'll introduce the healthcare workforce. Come back to me. I'm going to talk about some major issues, trends, and some policy levers. Uli then will examine an initial focus on workforce policy issues. I'll pick up a couple additional topics on that, and then we'll close with a brief discussion on some of the things that are going on around health workforce policy and planning at the community level. So Health Force Center is here at UCSF, and as Janet said, we're sort of the place to go for all things related to healthcare workforce. Just a news brief coming soon. We are going to actually launch a Health Force Center seminar series. So this will be quarterly presentations on emerging and important health workforce policy topics. So if you're interested at the end of this presentation and want to get engaged with us at Health Force Center and come to these seminar series, you can sign up for a newsletter or just email me. Next slide. Just a little history about Health Force. Institute for Health Policy Studies has been around for almost 53 years now. Health Force has been around for 33 years. This is just an example of the number of programs and research projects we've done over the years. We have a strong bench of researchers, which I'll go to on the next page. Next slide. So these are our core faculty across Health Force Center. We have expertise in, we have individuals from all 4 schools in the graduate division and folks with expertise from all different areas of the healthcare workforce, everything from direct care workers to nurses to physicians, dentists, anything in between. Next slide. And one more news note is that another thing we're launching at Health Force is the ability to affiliate with us. We have 3 affiliate faculty you see here currently. So this may be you're interested in health workforce studies, but it maybe isn't the main focus of your work, but is a component of your work, and you'd like to be connected with our work and our researchers in a stronger way. We are going to be doing a small online application. It's not really an application. It's just, to bring us into the fold. So again, either email me or sign up for a newsletter for that information coming soon. And I'll turn it back to Lily.
Well, thank you, Beth. So I'll start us off with an introduction to the healthcare workforce and who makes up the healthcare workforce. And it should probably go without saying, especially for this audience, that licensed workers need a license to legally practice versus workers with certifications that are sometimes more used to sort of indicate a certain specialty. And can also be at the state level, but most often is more of a national certification that indicates expertise. And we also have a range of unlicensed community-based healthcare workers. And so some occupations here are listed across all these categories. And so, for example, where do I have? Here, community healthcare workers can be certified or can be more unlicensed based on states. And you might ask yourself, where does the allied healthcare workers fit in? You may have heard of the term allied health, which is a term to describe all workers who are not part of medicine, nursing, or dentistry. And so speech and language pathologists or medical assistants could be a part of the allied healthcare workforce. Similarly, there are a whole another range of healthcare workforce who are not necessarily part of the functional clinical healthcare workforce under that definition, but who are also part of the healthcare workforce. And so these workers might be food service workers, housekeepers, janitorial staff, and laundry services, and there are many others. And you might remember that during COVID, these types of workers were classified as essential healthcare workers. Moving on to what are our largest healthcare occupations in the United States. For a very long time, these used to be registered nurses with over just 3 to 4 million workers really now. And they still are the largest healthcare occupation if you were to to separate home health and personal care aides. And not necessarily among the top 10 largest healthcare occupations, community healthcare workers. They're more on the slide provided at the bottom here for reference. They are up and coming and they're growing fast, so I included them here for reference. But overall, they are some of our smallest group of healthcare occupations in the United States. And so the next few slides are going to show you an evolution of how the occupations have grown and are projected to grow. So back in 2018, the projections were that home health aides and personal care aides among all the occupations in the United States were, close to like 35 to 40% growth rate that was projected here. But when we fast forward to 23 to 2033, you can see that this picture has somewhat changed. And on this slide, you have the projected employment until 2033, the actual numbers in 2023 right now, and the percent growth, as well as the new jobs that are projected to be added. And here you can see that the picture has somewhat changed, which would surprised me too as I was preparing the slides, that nurse practitioners now are with 46% projected growth rate among the top 3 fastest growing occupations. In general, this slide also shows you that healthcare occupation in general are dominating the fastest growing occupations in the United States, and home health and personal care aides are still here as number 10. And while their projected percent growth rate has somewhat changed, the new jobs that are anticipated to be added is still higher than some of the other occupations here. In addition to understanding healthcare workers by occupations, we might also be interested in understanding occupations within the healthcare industry. And this slide shows you in the middle of the circle here, the healthcare industry with occupations kind of mapped on the outside. And here the green part on the left-hand side, the non-direct healthcare occupations, give you a sense like how many non-clinical positions are a part of the healthcare industry. Similarly, we might be interested in understanding sectors within the healthcare industry. And here the slide shows you the large share that hospitals take among the sectors, as well as the residential and continuing care, nursing care, and home healthcare services make up another really substantial third share of the overall sectors within the healthcare industry. And the way that we are separating, I'm showing you this, it's like the occupation, healthcare, industry, sectors. These are all sort of data elements that we love to look at that you can obtain from the Bureau of Labor Statistics. And finally, this slide here shows you the trend by the numbers of workers in the healthcare industry. And if you look at the orange line in particular, you can see the growth just over the last a couple of years, specifically for the home healthcare industry that is noteworthy here. Some other characteristics before I pass it back to Beth are that really there's so many occupations in healthcare with a wide range of educational requirements. Many of them, probably the majority, really only require a bachelor degree or less. And some of our advanced professions, they obviously require multiple years of training and residency at times as well. So it's a lot harder from a pipeline perspective, to increase numbers among those occupations. The field in general is relatively female-dominated and diverse, particularly for the low to middle skill jobs and in long-term care, and individuals in low skill jobs are mostly concentrated in long-term care, experience high unemployment and low pay and few benefits. And I'll pass it back to Beth.
Lily. All right, next slide. So just to give a little bit of context of sort of where workforce sits in the national set of priorities, For those of you who've been around for a while, you'll remember when the triple aim became sort of the framework for thinking about how to address and improvements in the healthcare sector. I mean, it was really a way to move from sort of this trade-off perspective between quality, cost, and access to a more universal perspective of trying to reduce the per capita cost of care while improving population health and the experience of care. As many of the initiatives rolled out to try to meet this triple aim, those were really the well-being of the workforce was not included and led to a lot of dissatisfaction and burnout. Next slide. So the triple aim has been refined over time. It went to what was called the quadruple aim, which really brought in this idea of having an engaged workforce as part of the overall set of aims that need to be not traded off with one another, but being done at the same time. Currently, the most recent iteration includes health equity as the fifth aim in this sort of circle. Just to focus on the healthcare workforce piece of it, really improving the work life of those who deliver care. Just one example, electronic health records were really one of the mechanisms that was brought in to really, drive progress around the triple aim. And for anyone who's worked in clinical care, having to click 750 times, you could see how that didn't exactly improve the work life of those who delivered care. We also know from much research in healthcare as well as outside of healthcare that an engaged and satisfied workforce is more productive and provides better care. So really sort of the why that having a well-trained, healthy, engaged, and satisfied health workforce is important to overall healthcare delivery. Next slide. Unfortunately, we have a long way to go. There are a number of challenges. Many of the challenges we have today predate the pandemic, although the pandemic certainly exacerbated many of the issues, shortages, burnout, mental health crises. Uli already talked about the tenuous nature of the long-term healthcare workers, and also concurrently a real problem in rural communities with access to care and sort of an epidemic of rural hospitals closing. Next slide. So some of the issues and challenges, and this is by no means a comprehensive list, but thinking back to when the Affordable Care Act was passed, which seems like a very long time ago now, that really increased demand for healthcare by expanding insurance. 10 years later, when we had COVID, there was a drastic Medicaid expansion during the pandemic and the public health emergency, which was then followed by an unwinding that has created a lot of volatility in coverage and access. And that coverage and access really, who's seeking care, how they're seeking care, where they're seeking care, impacts how organizations and the providers that work within them can respond. There's a persistent shortage of primary care providers and mental health providers. Although, as I said, with COVID-19, there are shortages of providers across many, if not most, health fields at this time. For example, in my area, dental hygienists and dental assistants face very large shortages right now. Also, increasing demand may not necessarily spur increased supply. And Uli talked a bit about this, but there are constraints in licensure and education, limitations on educational capacity, whether that's, training of medical assistants and being able to have community college capacity for that, or really the very long pipeline to producing some of the postgraduate trained providers, dentists, physicians, nurse practitioners. So it's a long spigot, so you can't just turn it on and off. And in California, for example, just increasing wages may not necessarily spur increased supply, one, because of the education, two, but in California, we've raised the minimum wage, which is great, and it's even higher for many healthcare workers. But that also means that organizations that need to increase supply, that comes with an increased cost to them as well. And within the fee-for-service environment, that is still not a direct line. We have an aging workforce and an aging population. I'll talk more about the geographic maldistribution in a little bit, as well as the issues of workforce diversity. And while it is true that some of the more direct entry or direct care workforce is more female, that the professions tend to still be less diverse, and certainly less diverse in relationship to the population served. Next slide. So just to talk about geographic diversity, I'll focus on California. It's a pretty big place, and it has most of the elements of the nation. There's something called a health professional shortage area designation. We have these in dentistry, mental health, as well as primary care. This gives you an example on the left of the shortage areas for dental health. So the dark green are geographic HPSAs. That means the entire contiguous area does not have enough providers. The light green or the middle green is high needs, so that tends to be Medicaid populations simply have access, and population HPSA is actually the population HPSAs tend to be high needs. I mean Medicaid. The high need geographic often is where community health centers are. So you can see on the left, those are the areas that have dental shortages. On the right, those are mental health shortages, the same as much greater shortages of mental health. But just one point on the dental health, California actually has the highest ratio of dentists to population of any state in the country. And yet we still have about a third of the areas of the state do not have either a population or a high need access to care. And that is because we have such a low number of our providers who will accept Medicaid patients under Medicaid patients for dental care. Next slide. This slide speaks to the issue of racial ethnic concordance and the importance of that in the workforce. This is from a study about 10 years ago that I did with my colleagues, and we did a national survey. We were able to show that there's very high concordance between the race ethnic group of the dentist, being Black, American Indian, or Hispanic Latino, and the percent of their patient population. And particularly when you look at for example, the Black providers on average, their patients are 44% Black, and that's much higher than even the other two URM groups. And then when you actually look at the very, very low numbers of URM dentists in the workforce, we calculated that as of 2012, if we tried to bring the dentist population to parity with the US population, it would require almost 54,000 new underrepresented minority dentists. And in order to produce that is 10 years of all the graduates of every US dental school in the US. So that is a huge disparity. That is not a small difference. And this has been something that's been growing over time. And unfortunately, when we look at the current enrollment of, for example, Black providers in US dental schools, it is still at extremely, extremely low and not parity levels. Next slide. I will note that this lack of racial ethnic concordance is not just in dentistry. The Sullivan Commission report, this was back in 20 years ago, found that the fact that the nation's health professions have not kept pace with changing demographics may be an even greater cause of disparities in health access and outcomes than the persistent lack of insurance for tens of millions of Americans. So we see this in medicine, we see this in nursing, we see this in pharmacy. There are very large disparities between the population served and the profession serving them. And yet, we have a number of programs and policies that really prevent us from taking bold action against this. In 1996, Prop 209 was passed in California, prohibiting affirmative action. Of course, we had the 2023 SCOTUS ruling, which struck down affirmative action in college admissions, which would precede generally graduate education for most of the health professions. And then, of course, we are currently living through the executive orders against DEI. Not only the orders against DEI within the federal government, but direct attacks on educational institutions for their diversity efforts. Next slide. So what can be done from the federal level? There's a few things next slide, that's good. We don't have centralized planning for a health workforce. That's just not the way we approach health workforce in the United States. Many other countries do that, but we do not. But we do have some very big levers at the federal level. Most is done at the state level, and we will get to that in a bit. One big one is through payment. Centers for Medicaid and Medicare Services, just one example of the way that they have influence over the way that providers are utilized in the health system is through billable provider status, enrollment verification, and requirements that CMS has. So between Medicare and Medicaid, two of the biggest payers of healthcare in the US. And so this really shapes how staff and providers are utilized by healthcare system. Uli can talk more about the NP situation, but I believe that there are even disparities in payment where certain providers like nurse practitioners are not paid the same as physicians for the same service. So that is one way that influences can happen, both positive and negative, through the payment and quality standards. Additional quality standards are set by Joint Commission. This is accreditation for hospitals. There are a number of standards within that for health workers around patient care, infection prevention, a lot of hospital quality type factors, which are going to also impact sort of who is employed, how they're employed, and more organizational practices, but then that does influence kind of the demand for health workforce. The biggest the biggest federal lever that we have in around health workforce right now is through HRSA, is the Health Resources and Services Administration. I did hear that it was going to be renamed the associate AHA. I'm going to forget now. I've already put it out of my mind, but if it's renamed, it's going to be AHA. They have the National Center for Health Workforce Analysis, which runs a number of programs to strengthen the health workforce, including health workforce research centers, one of which we have here at UCSF, the Health Workforce Center on Long-Term Care. There are a number of others around the country that do most of the health workforce analysis scholarship that we see around the country. They also do direct loan and scholarship programs for providers, such as the National Health Service Corps. A lot of this is really to try to correct for the market failures. We have a free market approach to health workforce planning with all of the failures that I mentioned on the previous slide. And so really they're trying to incentivize folks to go to places that the market isn't necessarily going to get them to. They also provide institutional grants for pre-doctoral and postdoctoral training across a number of fields. They run the Teaching Health Center program, which I believe covers primary care and dentistry. There are a large number of nursing workforce awards, and many other things as well. But HRSA really is the sort of core federal agency that invests in health workforce, both in the understanding it and ameliorating some of the problems that lead to problems in access to care. I will say the Affordable Care Act authorized a National Health Workforce Commission, which was supposed to really, gather all this data and make recommendations to Congress around a better way to manage the health workforce, but it was never funded nor convened. They did do a number of state health workforce development grants early on, but those, I believe, have also been discontinued. All right, next slide. And then lastly, this is a really big one, graduate medical education. I will just say that it is complicated. It is primarily funded through a very complex mechanism of Medicare and Medicaid. There are also private payers. I mentioned some of the HRSA funding that goes into that. There's also funding that comes from the VA and Department of Defense. It goes to different sites. This really creates the container of the capacity of training we have for medical education. I believe also in dental education, some nursing education, I think podiatry, and I'm sure others that I'm not mentioning. But this is similar to CMS. This is a funding mechanism, and I thought this diagram was helpful in sort of showing how complicated that is. But again, there's no centralized place in the federal government that says we need this many nurses, we need this many things. There's lots of different efforts, and it's quite a cornucopia. So I will turn it back over to Uli.
Terrific. Okay, moving from national issues to state workforce policy issues, I will start us off with licensing and scope of practice. And as Beth was indicating, part of the problem with not having anything central and federal to get us organized, much of it is really the responsibility of the states. So key facts about licensing. So professional licensure is state-based and it varies significantly. It generally requires education and then an examination and generally also background checks. Training programs must be accredited by professional bodies. Licensure renewal requirements often include continuing medical education. And the cadence of license renewal determines often data accuracy, since much of our sort of forecasts and how many supply and demand projections rely also on having accurate data on people enrolling and graduating and licensing. And the renewal process, is it annual, is it biannual, is an important component of that. Okay, I already mentioned just this piece now. And so there are many states aim to have a state level minimum data set that allows us to also understand trends better across states. Licensure and renewal costs can be burdensome, especially for low wage workers. And at the same token, it's also a money-making industry in some ways to have these licenses be renewed on a regular basis. And licensing boards also handle disciplinary actions and complaints. Moving on to scope of practice now. So scope of practice defines who can do what, under what circumstances, and often is related to also the reimbursement of certain activities and services. There are multiple problems that scope of practice can cause. So some of the sort of negative consequences of scope of practice is that it can create conflict between provider groups over turf or reimbursement. It can vary widely and can restrict worker mobility as well as causing confusion among workers. It can limit access to care, contribute to inefficiencies or delays in care. And it's generally relatively well understood that it drives up healthcare costs since it reduces competition. I'll now dive into an example of scope of practice issues for nurse practitioners specifically. Here you see a map of the geographic distribution of the states that have enacted full practice authority for nurse practitioners. And full practice authority in general includes multiple things already. Includes like diagnosis and managing, but also prescriptive authority. What can nurse practitioners prescribe? Does this include opioid prescriptions? So there are nuances even within full practice authority. And one important piece to point out for this slide is that for California specifically, in 2023, we had the Assembly Bill 890 be introduced that allows NPs to practice without formal supervision after 3 years of practice and without any physician relationship after 5 years of practice. You see here that the color coding in the legend tells us that full practice authority after transitional period is blue, but there hasn't been an updated map that I've been able to find. So just adding on here that California now is a part of this number of states that are transitioning towards full practice authority. There is a really large evidence base that shows that nurse practitioners provide high quality care, often on par with that of physicians, or sometimes even better. And so, we have many faculty at UCSF who do work in this area, including myself. And so I'm just listing a few research examples here, beginning with work from Joanne Spetz, who's done some incredible work showing that access to opioid treatment is greater where NPs have full practice authority. Other colleagues have shown that the supply of NPs is greater and grows faster in states with full practice authority. And including work by myself and others has shown that full practice authority is linked to fewer emergency department visits, fewer hospitalizations, reduced cost, and better access to medications. And so again, this is just a small set of the issues that come with scope of practice and reason why this really matters in terms of access to care. For California specifically, the Bill AB 890 that I just mentioned also provided an ideal study context to examine if and how NPs might be intending to change practice. And of course, Joanne had the great idea to study this, supported by the California Healthcare Foundation. She administered a large survey to nurse practitioners in the states to really understand better like the practice patterns of nurse practitioners, and knowing this was in 2022 and knowing that this change was coming, how was this impacting, or how were they planning to change practice? And we found that NPs from marginalized backgrounds especially had stronger intentions than their white counterparts to open their own practice and also serve more Medicaid patients. So adding onto this literature that beyond sort of the direct clinical benefits that we've often seen in the research and the examples at the top of the slide here, this is really the first study to sort of also indicate that there are real practice change intentions under full practice authority. And so while I focused on NP issues just now in the previous slides, this is an issue that impacts many healthcare occupations. So again, it's really sort of at the heart of how the healthcare workforce often practices. And with that, I'm turning it back to Beth.
Thanks, Uli. All right, so in addition to state workforce policy on the regulatory side, sort of the licensing, certification, and all the examples that Uli just walked through, sort of the laws that allow people to come into the various occupations and what they do in those occupations. The state also runs a large number of health workforce focused programs. And again, similar to some of the programs at the federal level, a lot of these programs are focused on correcting market failures or addressing areas of need across the state that are currently causing problems for access to care. And particularly of interest for the state is access to care for Medicaid population across the state, which is sort of endemically underserved. Next slide. So something that's really unique that California has is something called the Health Workforce Pilot Projects Program. A number of colleagues, including Janet Kaufman, have done evaluations of pilot projects that have gone through this program. It's really unique in that in many states, in order to change scope of practice, you have to convince the legislature to change the law, to change the scope of practice around an existing profession or occupation before they can show what the impact of that change would be, because the law has to change before it would be legal for them to actually do these new things. In California, and I believe this was started in 1972, this program allows organizations to test, demonstrate, and evaluate new and expanded roles or health delivery alternatives before the change in licensing laws are made by the legislature. So this is really a great way to essentially provide a waiver to try something new and different, collect the evidence on that, and then actually bring that evidence back to the legislature and ask them to modify the scope of practice for different professions and occupations. So for example, California has a unique role, something called the registered dental hygienist in alternative practice. So this is a dental hygienist who, unlike most states where dental hygienists have to work directly for a dentist, they have to be employed by a dentist. In California, with a little bit of expanded training, hygienists can work independently, and they can work in long-term care settings. They can work in with schools and with students, and really doing a lot of things to improve access to healthcare. And they were able to get that change of scope of practice and change of their the regulatory status around their supervision through one of these pilot projects. And there are dozens and dozens of these that have been done. It really is a great thing that California has. And the other thing that it does is these scope of practice models tend to be very highly political. Nurse practitioners and physicians are still going at it. The dentists are fighting dental therapists coming to California, which we need, but it's always these political battles, and this allows, for what it's worth, some actual evidence in those discussions. Next slide. So this pilot project program is administered through the California Department of Healthcare Access and Information. For those of you who've been around for a while, it used to be called OSHPD, the Office of Statewide Health Planning and Development. Recent legislation changed a little bit of their scope, and really post-COVID infused a lot of new money into the programs and policies that HCI oversees around the healthcare workforce. One exciting thing, so unlike the Health Workforce Commission that was not funded at the federal level through the ACA, California has our version of that. So we have the Health Workforce Education and Training Council, which meets quarterly to really advise HCI, the governor, and other programs around the state, Labor Department, and so forth, around the various initiatives that are focused on improving the healthcare workforce. They run the licensure surveys that Uli talked about. So every 2 years, when people renew their licenses, there's a demographic survey that goes out. That data that is collected across all the different providers is now available in data dashboards and is being used for supply and demand modeling. So they've really been able to increase the capacity, not just to license individuals through the traditional board mechanism, but to really leverage that. And the medical board has been doing this for 20 years, and Janet Kaufman's been doing research with them for many years. So it's a really wonderful mechanism. that allows research and data to inform policy. They also run the California Primary Care Office, the State Office of Rural Health, so really focused on those areas of shortages and disparities. There are a number of initiatives. I've got them listed here. You can go on to the HCI website and learn about all of these different things. Behavioral health is really one of the main areas of focus since COVID, but currently also at HCI, really trying to enhance the behavioral health workforce and fill the many gaps in care for people in California. And building off of the mental health parity law that was passed federally, California has really taken that up. Still lots of work on nursing. Community health workers is a big area, particularly now that they can bill Medicaid, and there's been an expansion also to bill for dental case community health work, as well as a new addition to their capacity. And then also post-Dobbs, California implemented constitutional amendment protecting the right to abortion, and there are a number of reproductive health care initiatives as well. And then finally, HCI also runs a lot of health workforce financial assistance. So similar to what I talked about with HRSA at the federal level, the HCI is sort of our California HRSA in some sense. They provide scholarships for a whole host of different types of providers, again, with the focus on those that are either shortage or maldistribution, also loan repayment programs, as well as grants for organizations. HCI does a number of other things as well, but these are really the kind of three big buckets that they're working in to support California's health workforce and help fill some of the gaps that we see just from the market approach to supply and demand. Next. And then I just have a couple more things I wanted to focus on. So, most workforce policy, health workforce policy really is state. There are regional and local approaches. Obviously, we haven't touched much on the educational pathways and educational system that's obviously also also governed by a lot of regulatory and funding processes on the education side, not just the health side. But I wanted to highlight, next slide, one initiative that we are currently working on here at Health Force Center. We have a grant from the California Endowment to develop a workforce policy entity. So we're calling this Policy at Health Force. This is really taking all of this research that the folks that have worked here for many years and really put that and make that accessible for folks that are working to advocate for changes in health workforce policy or improvements in health workforce supply, demand, distribution, diversity from communities themselves. So we're partnering not only across, so for example, CBOs and HCI and education, but with a group called Health Career Connections that is funding a number of regions to improve their health workforce collaboratives. So across the state, at a regional level, there will be a number of health workforce collaboratives focused very much on focusing. California's huge, urban, rural, north, south, desert, mountains, all the things, right? So really, like, what is that local capacity? What is the educational capacity? What is, from K through 12 to college to post-secondary? What are the needs? And really bringing in the multiple stakeholders. So these folks will be talking to folks at the state level and talking to folks at the federal level, but also working regionally and to really address their health workforce challenges. And last slide, just a couple examples of what some of these career pathway programs may look like. So they're traditionally focused on underrepresented or disadvantaged backgrounds, but it really regionally focused here on trying to build their own, or have folks that grow up and are in a community be able to get the training education they need to work and provide care in those communities. So some examples are K through 12 partnerships for STEM, trying to get folks from K through 12 into community college. There's extensive investment across the state in our workforce investment boards. That's a state level initiative. And then the California Workforce Association that really focuses on capacity at the community college for developing the healthcare workforce. There are a lot of post-baccalaureate programs. These are programs when you graduate from college that help prepare you, or we also call them now pre-health programs, that would prepare you for going into a health career. And then at the health, within health professions education, there are also programs such as UC Prime, funded again by the state, but rolled out across the different medical schools in the University of California system that focus on recruiting and some specialized education for people to become physicians to really fill needs in the physician workforce that are not being taken care of otherwise. So this is just a couple samples. There's probably 25 other things that examples that ones could give, but just really taking us from the highest level and sort of who's in the workforce with the federal, state, and then this is sort of what the community and local level types of activities to influence policy and really help improve the health workforce pathway and pipeline look like. So that is the end of our discussion. Uli, do you have any closing thoughts?
I think that was great. Thank you, Beth.
Yeah.
Hey, yes, thank you, Beth and Uli. Yes, that was I think, very informative presentation. You packed a lot of very important and useful information in that. So I invite our audience to put questions in the chat. I mean, the Q&A forum. Put them in the Q&A forum, and we'll read them. I will maybe kick us off with sort of an observation and ask for your reflection. I think given the current environment we're in, the focus on state level policy is even more important. Our states have always played critical roles, but I think given the current climate in Washington, D.C., it's reasonable to surmise that the federal government, at least in the near term, is not going to show a lot of leadership in this area. Particularly around diversity and inclusion. And so I think, a second thought related to that is that, really, successful advocacy for change at the state level really requires, as you say, state folks to hear from folks, regional, local folks. And I just want to get your thoughts, I think, on what does it take for effective collaboration there? And I say that because for a project that I'm working on now in a particular county, it's clear that there are some folks in the county agency who kind of take the view, well, education just should figure it all out for it. They should do what we want. And why would we ever get involved in trying to partner with them? They should just do it. And when you talk to the educators, and the educators say, well, we would love to do it. That said, we need sites at which to place our students so that they can get their clinical education. So how do we, and I don't know that we have a one answer, but what can be done to get folks in education and care delivery to, A, effectively partner locally, and B, effectively advocate with one voice?
That's a great, that is the question, isn't it? I think that, I mentioned the California Endowment Grant. They are also funding this Health Collaborative Development Grant as well. And I think that's exactly what they're envisioning and why they're investing in this. So at the regions. And these health workforce collaboratives already exist. So some places have them, some places don't. Some they're sort of nascent and they need to be developed. Others are very sophisticated. For example, one in Coachella Valley that's been going for quite a while. And I can speak just having spoken with them directly about their work. They bring industry to the table. They bring the K through 12 education to the table. They're bringing the community college to the table. They're bringing the higher education to the table. They're bringing all of those folks to the table to say, agree on what are the priorities that they want to work on, and then figure out exactly what you're saying. What can be done in this, but then where's a handoff, and what can be done here, and then where's the handoff, and then where are there either policy barriers, funding barriers, other gaps that come up as the group collaborates, where that can turn into that sort of one voice of advocacy. Like we really, one of the things that has been brought up, and I believe there's work at the state level around this, is sort of getting credit for on-the-job experience. So you've been working on the job for many years as a dental assistant and you want to go on, but you have to go back to school to relearn things maybe you already know from on the job. And so sort of getting some of that to really move people through that educational system faster to the goal, which is we want them to be practicing and be available in the community for care delivery. That's just one small example, but I think that those types of collaborations that are rooted in the community for the community are really, and I think for us, for UCSF and for the researchers here at HealthForce and others, playing a supporting role in that, when there's data that's needed or technical assistance or, but certainly not leading it. This is really saying like, we can provide this broader, set of context around, like the work that you all do around informing policymakers and being able to like understand how to do that advocacy, those types of things. But I think that would be my general response, Janet, as what we're hoping will be effective, and what has been effective in the past for the communities that have pretty well developed workforce collaboratives.
Okay. Uli, any thoughts?
Then as Beth was saying, that is really quite the question. You asked us to comment on. I was thinking, just about how also this the critical role of, some of the work we have done with OHCA, the Office of Healthcare Affordability and Access, on so the workforce stability, right? There's so much change right now, and like having advocates who are sort of monitoring how this is all impacting certain healthcare providers and making sure that we can, across healthcare workers, ensure equity is, any collaborations that can be a part of both monitoring the trends as well as, securing funding towards supporting sort of more workers that are impacted under these circumstances, I think would be really helpful.
Great. Well, thank you. We're almost at time. So I really want to thank Beth and Uli for their presentation. This presentation is being recorded, so if you have colleagues who missed it that you think would benefit, it will be available soon on the IHPS website. Also, want to let you know that you'll be getting keep your eyes open in your email for a survey link we're going to send. Since this is the last of our webinars for 2024-25, we would really like to hear from you, our audience, about what you would like to see us do in the next academic year. This year we pivoted from, skills development to content with 3 sessions on insurance in the fall, and then regulation of drugs and devices, payment models, and workforce this spring. So really, we want to know, would you like more of this more content approach? Would you like us to go back to skills? Are there particular topics or skills you'd really like to learn? Because Dr. Griffiths and I put this series together for you and your colleagues, and we want to have this as a series that really, fulfills some of your professional development needs and those of your colleagues. So thanks, everybody, and have a good afternoon.
All right. Thank you. Bye.
Okay, bye.